And thank you for joining us on today's Invisalign ClinCheck Case Template webinar with Dr. Doug Brandt and Dr. Mark Hodge. You'll earn 2 CE hours for attending today's program, and you'll receive important instructions on how to obtain your CE certificates at the conclusion of the presentation. Please note you're able to listen to today's program via the webcast, and throughout the webinar, you'll have the opportunity to ask text questions which our presenters will answer at the conclusion of the presentation. I apologize in advance we're unable to answer everyone's questions since our time is limited, but we will follow up after the program to answer any outstanding text questions. It's now my distinct pleasure to introduce today's speakers, Dr. Doug Brandt and Dr. Mark Hodge. Dr. Doug Brandt is the University and Strategic Partnerships Manager at Align Technology. He's been in private practice for the last 31 years and has a large adult patient base. Involved in orthodontic and occlusion education on both the undergraduate and graduate levels, he is on the cutting edge of the latest technologies and how they can be used to improve our dental knowledge. Dr. Brandt received his DMD from the University of Saskatchewan and his MS and certificate in orthodontics from the University of Detroit. Our second speaker today will be Dr. Mark Hodge. Dr. Mark Hodge reached the level of Invisalign Elite provider in 2008 and has been treating Invisalign patients at his Broken Arrow office since 2002. Dr. Hodge was the only dentist in Oklahoma to receive Elite provider status in 2008. Since receiving his Doctor of Dental Medicine degree in 1985, he served on the dental school faculty of both Oral Roberts University and Loma Linda University. Dr. Hodge is currently one of the clinical directors at Heartland Dental. So without further ado, I'll turn the program over first to Dr. Hodge. Dr. Hodge, you now have the floor.
Thank you, David, and it's an honor to be addressing the group today, and even a greater honor to be joined by Dr. Brandt, the actual developer and creator of these templates. And I've just had the privilege of working with Dr. Brandt to customize these for Heartland's use, and I know many of our doctors know Dr. Brandt from his providing our Clear Essentials certification and the various webinars that he has presented.
Thank you very much, Dr. Hodge. Most certainly it's a pleasure to be here. This is a very exciting presentation and a very exciting concept that we've been putting through a number of phases in probably the last 10 years. The idea first came to me, I would say, back in about 2000, and even while in private practice, you can see that very often you have orthodontic sort of similarities. In other words, you'll treat one case, the patient will walk in and you'll look at it and you'll say, boy, that looks very similar to the last one I treated. So what we're trying to do is sort of bring this together in a more innovative, inventive way, and trying to put together these case templates so that you can look at your patients and have some greater guidance, more guidance in terms of how to approach the case and treatment. So I'm going to turn it back to Dr. Hodge now, and he's going to discuss the case template process and lead you through that, and then I'm going to come back in afterwards and we're going to talk about specific case examples and how to use this.
Thank you, Dr. Brandt, and I would just echo that really this whole concept in today's presentation is in keeping with Align's new cooperative partnership with Heartland Dental Care. And today we launched this as a major initiative, the Invisalign treatment templates, and I believe it really has the potential to totally revolutionize Invisalign orthodontics in the general dentist practice. And today our agenda encompasses 4 main points. We're going to look at the need and the rationale for having case templates, the armamentarium involved. We'll go through the instructions on how to use the templates, and then Dr. Brandt will actually be walking us through some case examples so to aid in our understanding of that. If we look at the need for templates, in terms of our overall Heartland goal of achieving mastery at all levels, we have to recognize the fact that inside Invisalign orthodontics, there is a learning curve that varies with the practitioner. And our desire is for a good experience for both the patient, the doctor, and the team at all levels, from the very, very first patient we treat all the way to the last. So it begs the question, if there's anything we could do that would facilitate the learning curve and improve the outcome for both the patient and the practitioner, it merits further evaluation. And that's what actually led us to these templates. Heretofore, the doctors were pretty much limited to gaining additional help through using Invisalign Assist, which is a great option, but it is only offering limited movements. And so the templates will actually allow a doctor to use Invisalign Full and harness the full capability of Invisalign's technology and software. The other things that relate to the need for a template is the fact that we are all general practitioners, and the quality of our case outcome is judged not just by the finished results, but we're going to be seeing these patients for years and decades to come, and they are looking for a long-term, stable relationship in their occlusion, and that's part of the template design as well. The other thing that's unique to Heartland that also merits the need for these templates is because of our dental service organization's status, we have within the group patient transfers and doctor relocations, and so if we could establish consistency in approach to care, then we're going to get more consistent outcomes and better satisfactions for our patients who are very mobile and tend to move, as well as doctors who may relocate and be taking over cases that were started by another doctor. So in summary, the need for templates, it's because of the dichotomy that exists between Invisalign's very, very predictable nature. I mean, having treated over 2 million cases, the software is very predictable, but at the same point, on the other side of the equation, we have common pitfalls and struggles that doctors face. And so the template is a way of bridging those two realities. On a day-to-day basis, we see doctors often get undesirable or unrealistic ClinChecks, and it comes from a variety of factors, and the templates will help us overcome these factors. The most common things that relate to an unrealistic ClinCheck or an undesirable result is the doctor never optimized their preferences within the Invisalign software, or they're not using the Invisalign prescription defaults, and the defaults are they're made to help simplify the outcome for the case. The other thing is the doctor could be unfamiliar with the actual clinical implications of the questions they're being asked, and so the templates will help overcome that potential. A very, very common element that would affect the unrealistic outcome is if the case is being built upon inferior photos that lead to an inaccurate bite set, so we'll be discussing that today as well. And the other thing that has a factor is the variability that exists between a doctor and technician pairing. And we'll be talking about how with these templates, our Heartland doctors are going to be serviced by an elite team of Invisalign technicians to help us in consistency with our case outcomes. So the good news is that malocclusion, although it comes in various forms, like Dr. Brandt was mentioning in our introduction, it comes in various forms, but there are patterns that repeat themselves within the malocclusion types. And if we use these patterns that exist in malocclusion, that allows for patterns in treatment. And so that brings us to the rationale for developing templates, because our whole goal is to improve the clinical outcome. And the templates will give us a way to do that. If we can improve the outcome, that increases the doctor's confidence, which will yield increased treatment planning. It'll also increase the team's confidence, which will increase the times that they're preheating us to patients' needs for treating their malocclusion. And it will be lowering frustrations and all the uncertainties that can come when you're first learning about Invisalign. This will lead to increased efficiency, and that's lower chair time. As we have increased patient satisfaction, they will be referring more patients for further treatment, so it builds our practices and it builds our confidence at multiple levels. And as the doctor's confidence increases, the team's confidence will increase, and that will lead to more malocclusion conversations, and that helps us accomplish our goal of getting our patients healthy, that our patients will get the care that they need, desire, and deserve, and that's what Heartland's all about. So in terms of rationale for how we can use templates in something that is sometimes considered as complex as orthodontics, there are certain realities that exist that make templates very, very reasonable and efficient in accomplishing our goals. One of those rationales is we all realize that a Class 1 occlusion is desirable and is very often achievable. And while that will be our gold standard, the reality of orthodontics, and Dr. Brandt will speak to this, that sometimes overreaching for that Class 1 finish will significantly decrease the predictability. It increases the chair time, and it also increases the potential for relapse. What some general practitioners may not be aware of is even this quote from the American Journal of Orthodontics that says that 90% of orthodontic cases relapse when retainers are removed, and very often that's because the goal was you were overreaching for the goal. So part of the way what is built into the template is we are looking for a predictable, stable, long-term occlusion for the patient. And being able to discern which patients are suitable for achieving the gold standard of Class 1 occlusion and which ones are not, that is something that's just based upon experience. And the beauty of these templates is the templates embody decades of experience from Dr. Brandt and myself, and it's going to give the users the best blend of efficiency, predictability, and stability, which will be retention. And Dr. Brandt has researched this for quite some time. I think he said he's been going back as much as 10 years working on this concept. So Dr. Brandt's going to speak to the fact that there's a rationale behind these templates.
Yes, thank you, Dr. Hodge. Most certainly, I tried to put together kind of a diagram or a schematic of what I believe orthodontics really entails. And many times today we think about orthodontics, especially with Invisalign or anything else, even in terms of fixed appliances, that because of the innovation, because of what's happened in the orthodontic field, oftentimes we think that the system or the software or the computer kind of runs the whole process. And we still need to go back to sort of this type of pyramid which is very sustainable, where we need to have just some basic principles of orthodontics and occlusion. As we've talked many times, and you've heard me speak, it's really important that people that are treating cases orthodontically really need to understand occlusion very well, and that's what it's all about, is just trying to fit teeth together, almost like doing a denture setup when you're setting up these teeth. And if you've got the basic principles as your foundation, and in orthodontics and occlusion, most certainly, then building on that with education and experience allows you to take the innovation and make it work for you. And what we're doing here with the templates is we're assuming that you understand the basic principles of orthodontics and occlusion, which I know you do, and then as you treat more cases, as Dr. Hodge was saying, and gain that experience, the innovation's there just to help us move us forward in that area. So this is just the opposite, and this is probably is not very sustainable at all, is like I mentioned to you before, is if we use only innovation and assume that everything that's sent back to us through the computer and through the software is going to work out perfectly without having the education and experience and the basic principles in orthodontics and occlusion, I think that's something that's not going to, sustain us through our cases and give us the results that we need. Dr. Hodge?
Thank you, Dr. Brandt. And really, that really speaks to the nature of what we have planned into the templates. And what's going to be amazing to our listeners is to find out just exactly how simple this is. And so the innovation is one of simplicity and predictability that is based upon the fact that there is a reproducibility of certain treatment approaches. So that brings us to the point of the armamentarium that we'll be using in working with these templates. And the simplicity of this is that what the doctor will need is articulating paper, floss, a mouth mirror, and a periodontal probe, and then simply a ballpoint pen and the template grid that you see pictured on your screen. And we'll be referring to that template grid quite a bit during the remainder of our presentation. In fact, we believe that using this template grid will become part of the normal Heartland Dental Care knee patient exam, where while the hygienist is doing their full mouth periodontal charting, they'll simply use the probe, make these 6 simple, quick assessments, and preheat the doctor to the potential for treating malocclusion for this patient. And so let's look and see how this is all going to interrelate. So first, by starting with the articulating paper, you will want to mark the centric occlusion, maximum intercuspation of the patient before you take the occlusal photos. The success of all your cases, and particularly in using the templates, is built upon quality photographs that include articulating paper markings, and then the lateral photographs that are perpendicular to the bicuspids, just the same as if you were taking a bicuspid bite wing. You want your digital camera oriented perpendicular to the bicuspids. This will help the technician in setting your initial bite. If the initial bite is correct, the outcome is going to be more predictable and efficient. A correct bite set will lead to increased predictability, fewer case finishing refinements, or fewer cases finishing with anterior interferences, and fewer refinements. Thus, we have an improved outcome for improved efficiency and predictability as well as profitability. So, as I mentioned, we will be using this template grid that you see on your screen with a series of colored dots. You'll be making 6 assessments. And on these 6 different categories, you're going to make 3 choices. And your choice is between normal, mild, or moderate. So all of the normal options are color-coded green. The yellow is mild, and the third choice would be moderate, which are color-coded red. And the easiest way to remember this and how to classify it is all of the all of the mild classifications, the yellow, are built upon the same degrees of average or normal that you find in measuring periodontal pockets. So we're using a periodontal probe to make these occlusal analysis, and the measurements are the same as for periodontal pockets, where 3 to 4 millimeters is considered normal or average. The same is true in this middle row of columns. If you're making an assessment of overjet or overbite, if that 3 to 4 millimeter range is what's going to give you that mild classification. So that'll all come clear as we go forward in our presentation. So the other part of your armamentarium will be dental floss. And so by taking a string of dental floss and simply positioning it in the center of the bridge of the nose, the filtrum of the upper lip, and the center of the chin, you'll be able to ascertain, is the maxillary midline correct. If it is not on line with the middle of the face, then you'll just note the deviation from the normal or the midline in terms of millimeters. Further evaluation of the midline is done with the teeth in maximum intercuspation, and you're comparing the upper midline with the lower midline, and that's your first question on your template grid. And so if the 2 midlines are aligned, then it's a midline of 1, which would be the green box. If the deviation is less than 2 millimeters, then it would be the midline of 2, the yellow box. If it's greater than 2 millimeters, then it's a midline deviation of 3, and the red classification, your third choice. So you simply would make that assessment and then mark that right on the grid. Next on your grid is analyzing the AP classification, which is something we're all very familiar with in terms of Class 1, Class 2, and Class 3. One of the things Dr. Brandt has educated me on is that what is most informative in terms of determining the classification is not looking so much at the molar or canine, but just looking at the bicuspid arrangement. So if we compare the cusp tip of the upper first bicuspid with the embrasure of the 2 lower bicuspids and how they relate, the cusp tip of the upper bicuspid should bisect the interproximal contact between the 2 lower bicuspids, and that would be considered Class 1, or your first, the green box on your classification on your grid. Now, there is a little bit of variation that can exist. A 1 to 2 millimeter difference would still be classified as Class 1 in the use of the templates. Now, we use that same criteria looking at the lower embrasure relative to the upper first bicuspid. If that embrasure is distal to the upper first bicuspid, then that would be a classification of Class 2. And that's, you're going to have an AP difference of a negative 3 to 4 millimeters in determining a Class 2 relationship. Conversely, if that embrasure space is forward of the upper first bicuspid, that would be a Class 3, and where the mandibular teeth are advanced forward of the maxilla. So again, you'll be making that assessment using visual inspection, and you can use your periodontal probe to help orient yourself. So after marking the midline, you'll make your AP classification and then just simply mark the corresponding assessment that you see on the grid. So the grid becomes a very active part of your evaluation. If the anterior-posterior relationship is different from one side of the arch to the other, let's say the right side is class 1 and the left side is class 2, then you're going to mark you will use the highest classification. So if you had a mixture of class 1 and class 2, you would just pick class 2 because that's the higher classification of the two. So now we've answered our first two questions on the grid. We move on to the third, which is determining the overjet relationship. And it's important to note that overjet can be both positive or negative. And negative overjet is sometimes referred to as underjet. But for the sake of our form, we're just going to refer to it as positive or negative. So looking at the overjet relationship, a positive relationship would either be a normal overjet of 1 to 2 millimeters, which would be your green box on your form. An overjet of 3 to 4 millimeters would be an overjet of 2. And again, remember that 3 to 4 millimeters is our baseline, just like for periodontal pocketing. 3 to 4 millimeters is our baseline of what we would consider average or normal in terms of overjet or overbite. And then if the overjet is above 4 millimeters, then it would get the third ranking on our grid or our form. And then if we look at negative overjet or underjet, if you will, if the anterior teeth are edge to edge or the upper anteriors are behind the lower anteriors by up to 2 millimeters, then that would be a negative overjet of 1 on our form. And I'll show you how this works on the form in just a moment. If the overjet is more significant, of up to 3 to 4 millimeters of negative overjet, then it would have a negative overjet of 2, and again, above 4 millimeters, a negative overjet of 3. Now, I know that's a lot of numbers and a lot of different measurements, but if we use the form, it all becomes quite simple. So let's go back to our grid, and we're looking at just the third line here of overjet. Your first thing you're going to ask yourself, is this a positive or a negative overjet? And then you're just going to circle that you have a positive overjet and then make your assessment. So this would be a patient with a positive overjet of 2. If you had a class 3 patient or a patient with an anterior crossbite, then you're going to have a negative overjet. You'll circle that and then just mark to what degree. And again, your middle classification is the same as periodontal pockets. 3 to 4 millimeters would be your yellow bubble on this form. So that's your reference. Anything less than 3 to 4 millimeters is a 1. Anything greater than 4 millimeters is a 3. So it's quite simplified and easy to recall. So if we look at the middle picture on your screen, if we're making that live assessment on this patient, it is indeed a positive overjet. So you circle the plus sign, and then you make your millimeter calibration. It is less than 4 millimeters. So that would be an overjet of 2, positive overjet of 2. And now we'll look at overbite, and we'll classify overbite at the same time. It is a choice between having an overbite or an open bite, and that's the same line that's on our little form here. So overbite would be that vertical relationship or vertical overlap between the upper anteriors and the lower anteriors. An overbite of 1 is 1 to 2 millimeters. An overbite of 2, again, 3 to 4 millimeters, just like our normal periodontal pockets or average periodontal pockets. And anything greater than 4 is an overbite of 3. If a patient does not have any overbite, then they would be classified as open bite. And we'll look at that in just a moment. But let's look at different ways of assessing the overbite. Most often that can be made just by a visual inspection because you're just using the 4 millimeter guide as your mid-range. And so if you want to be a little more precise for the C personalities that are in our midst, if you want to be a little more detailed in that, you can actually mark the anterior occlusion with articulating paper have the patient bite firmly on a strip of articulating paper, and then take your periodontal probe and simply press against the lower anteriors, moving your probe left to right, and that pressure will create articulated paper marking on the facial of the lower anterior. Then measure from the highest point of that marking to the incisal edge, and that will give you your amount of overbite. So then you're just still looking at your classification, overbite of 1, 2, or 3, and the mid-range is 3 to 4 millimeters. You're going to hear that over and over. So like I said before, in the absence of literal overbite, the only other option is one of open bite. And so same numerical classification. If you have a separation between the incisal edges of 1 to 2 millimeters, that would be an open bite of 1. Separation of the incisal edges by 3 to 4 millimeters is an open bite of 2. Greater than 4 millimeters, open bite of 3. And you'll see in the lower drawing, you will always measure the point of greatest separation. And so that's the reason we went to the lateral incisor there in the lower picture. So if we look at our fourth line on our series of 6 questions for the template, you're first going to just determine, does this patient have overbite or do they have an open bite? So for overbite, you're going to circle OVB, the abbreviation for overbite. If it's an open bite, you're going to circle OPB for open bite, and then make your classification based upon the millimeters of analysis. That brings us to our final 2 questions. And with this, we're looking at the individual arches. For the upper arch and the lower arch, you're going to answer the basic fundamental question: what's the problem here? Is it crowding or is it spacing? And whichever the problem may be, if the problem is confined to the incisor area, that will be classified as mild. If the problem, be it crowding or spacing, extends to the canine or cuspid area, that would be considered moderate. If the problem extends from incisor, cuspid into the bicuspid area, then that is considered significant, or our third classification, the red marking on your bubble diagram. So let's look how this looks in a clinical application. So here you see different arches, upper and lower arches, all with crowding. So on the far left, the green markings show crowding of the upper and lower arch that is limited just to the anteriors, the incisors. The middle drawing, the crowding exists and extends back to the cuspids or canines, and then the third category, it extends back to the bicuspids. Now, within any particular mouth, you could have an upper crowding of 1 and a lower crowding of 2. So you're making your assessments based upon the arch, and we'll make those independently. If the problem is not crowding, but that is spacing, it's the same thing. You're looking at incisors only, would be an assessment of 1. Incisors plus cuspids would be a classification of 2. If it includes the bicuspids, then it's a classification of 3. So if we bring this into perspective using our grid once again, you would look at your 5th question, and for the upper arch, you're going to circle either C or S. For crowding, you're going to circle C and then make your assessment. So if we were making an assessment for the middle arch that you see on the screen, you have crowding that includes incisors and canines, so that would be crowding assessment 2. If we were looking at this lower arch, the last one on the screen there at the bottom, it extends back to the bicuspid, so you have lower crowding 3, and that's the way you would mark your form. If we're dealing with spacing, the top image you see there with spacing, limited to the incisors, that's spacing category 1, so you circle the S on your form for spacing and simply put an X over the 1. Lower spacing of 2 would be noted on the form by circling the S and then just marking the yellow bubble for 2. So it's a very straightforward assessment that has consistency. And you are looking to make 6 assessments on your grid for every patient. You're making 6 assessments, making 3 choices of normal, moderate, or mild. And mild, again, is that 3 to 4 millimeters that we all accept as being a range of normal within the periodontal world. Now we're bringing that over into the world of malocclusion as well. So once you have this form, let's just do it here live using this picture as an example. So let's just walk through it step by step the way you can start using your templates starting tomorrow or Monday morning. We look at this patient. They do have a midline deviation, and that midline deviation is greater than 2 millimeters. So we would mark midline of 3, classification 3. And although we do not have lateral photographs to illustrate here in the PowerPoint, this particular patient does have a classification of class 2 if we look at the bicuspid arrangement. Now we're going to assess overjet, and obviously this patient has a positive overjet because there's no open bite, so we're going to circle the plus sign, and then we're going to make an overjet assessment of 1 because the overjet was less than the 3 to 4 millimeters. Now we're going to make our assessment of overbite or open bite. There is no open bite there, so we're assessing overbite, and the overbite is the 1 of 2. Upper arch is crowding. Obviously we have crowding of level 2, and the lower arch is the same, crowding 2. So that is your template assessment for this particular patient. It's just that easy and straightforward. So with every form, you're going to be making 4 circles and 6 X's. So you're going to circle, you will circle for overjet, overbite, and then whether you're having crowding or spacing. So you're going to have 4 circles on your form, and then you're going to mark an X on each of these classifications. Once you have this, it's very diagrammatic. If you look at this form relative to the photo, what this tells you is that the only aspect of this patient's treatment that has any degree of difficulty is correcting the midline. That's the only red bubble you have marked on for this patient. Every other aspect of their malocclusion falls within the normal to mild level of difficulty in terms of Invisalign predictability. So this case will typically be one of a shorter treatment time, lower chair time. This will help you gauge your assessment in terms of setting a fee. And so it's going to be a very, very powerful tool going forward. As you finish the presentation today and have an opportunity to earn your CE credits, you'll have a question like this where you'll actually be able to complete a form where you'll get to practice this using some photographs. So now that we have an understanding of how to use the template grid, we're actually ready to fill out the Invisalign prescription. So what you do is you'll take a photograph of your completed template grid and just take that with the same camera that you're taking the photographs for your Invisalign photographs for your patient. Now the submission process using the templates, the submission process for your case will be identical to how it's been before. But you do need to set your preferences to match the Heartland recommended preferences for Invisalign. And with the presentation today, you will be able to actually download the document that lists the recommended preferences. So I recommend that you go in and as soon as you finish the presentation, change your preferences so they match the recommended preferences so you get maximum consistency in using the templates. And you'll be using Invisalign Full or Invisalign Teen going forward for your cases. And we're going to want you to use all of the defaults that are on your question forms. And another download that you'll have from this webinar is a completed prescription form showing what all the recommended defaults are. So by using Invisalign Full, having your preferences set for consistency and accepting the defaults, your grid and the templates will help drive your case toward efficiency, predictability, and stability. And looking at your prescription form, the question that most often causes doctors consternation is question number 10, and that is, how am I going to address the crowding and spacing? When using the templates, what you'll want to do is just simply check as needed for all of the options, because this is built into the templates. And once you've used your template grid, you will not have to fret over what's the best option here. That has been all pre-thought out based upon the decades of experience of Dr. Brandt and other providers. So very simply, as you get to the point of uploading your photographs, you'll see how we already have the patient's photographs uploaded here. It's time to upload x-rays. So you will upload your Panorex or your FMX, and then there is a second option of uploading a cephalometric x-ray to the x-ray field inside your prescription. Rather than uploading a second x-ray, you will import the photograph you took of your template and then just simply drag it across, and the prescription form will recognize that, and that will go directly to your technician. So that prescription grid is your communication tool for unpacking all of Dr. Brandt's expertise into your ClinCheck and getting that information right to your technician. Then once you've uploaded that template grid, you will face question 11, which asks for special instructions, and your special instructions can be just as simple as 3 words: use Heartland template. And with that, your technicians will develop a ClinCheck for you. The beauty of this is, rather than having your cases go to one of the 600 technicians in Costa Rica, we have put together an elite team of technicians that are cross-trained on using these templates. Dr. Brandt has helped select these technicians. I'm flattered that it includes the technician that I have used over the past 10 years. And so we've developed a high degree of consistency. They're very familiar with the templates and how Dr. Brandt would set up these cases. So in essence, it is going to be like having Dr. Brandt standing there with you developing your ClinCheck. All you have to do is, for those 6 assessments, you're going to simply check either a green bubble, a yellow bubble, or a red bubble, get to your special instructions and say, use Heartland templates, and then you're going to get a well-thought-out ClinCheck in return that's based upon efficiency, predictability, and stability. And so I can't thank Dr. Brandt enough for having put this innovative concept together and making it available for exclusive use for Heartland at this point. And that's how we're actually going to use the template and the grid. I think that all of our doctors listening now have a better comprehension of the level of intricacy that you have built into the templates. And the point value and the differentials between the point value of an assessment at the initial treatment and the point value at the conclusion helps us determine what is the best or the most appropriate treatment choice. The good news for the doctors listening is you don't have to concern yourself so much with the points. That's built into the templates. The goal of the template is to keep you from overreaching and building in a lack of stability. So if you have a form where you have checked several of the red classifications, the most predictable template will be moving red to yellow. If you have a lot of reds that you're going to try to move all the way to green, it does not mean it's not possible, but it's probably not going to be the first template you get back, because that's going to be more challenging and also less stable, and you're more likely to have relapse. So that's the way the point systems are kind of working on your behalf behind the scenes. The main thing you need to do is make your assessments, checking your green, yellow, yellow, or red. If you get a lot of reds, do not think that it means no treatment. That just means it's going to be a little bit longer treatment. And we're going to be typically moving the reds to yellow and moving the yellows to green, and then you're going to have predictable outcomes that are efficient and stable over the long term. So that is the innovation that we've built into the templates. It's a partnership between Invisalign, Dr. Brandt's expertise, our dedicated group of elite technicians in Costa Rica, and our dedicated doctors serving their patients in their individual practices throughout the states that the Heartland offices are in. So doctors, I thank you for your time and your attention, and I encourage you to download the forms that are available. You'll get some instructions on how to earn your CE credits, and this will dramatically increase the level of support you have for your cases. It'll be like having a co-diagnosis in setting up your treatment plans. Your cases are going to finish easier, more predictable in less time, and be more stable in terms of retention long term. So all of our patients will move forward in getting the care they need, desire, and deserve. Thank you for your time and attention, and I wish you the best of success.